Thank you very much for the kind introduction. And today I'm going to talk on newer advances in optimizing endometrium for implantation. So we all know that endometrium is very, very crucial. We have got lovely embryos and everything, and then we do not get good endometrium. And it is very, very dissatisfying situation. And we all know that endometrium is a complex multicellular steroid-targeted tissue of stromal, epithelial, vascular, and immune cells, undergoes inflammation, angiogenesis, and formation of new tissue. And what is ideal endometrium? That is what we all want. An endometrium which is good tree line with good halo and thickness of more than 8 millimeter with good vascularization up to the zone 3. And even these days with good ultrasound machines, we have understood that endometrial volume is also very good. So we want a good volume. And we have understood that most pregnancies occur in volumes of more than 2 to 13 milliliter. And there are biomolecular markers of implantation failure, and these are macrophages, the NK cells, estrogen and progesterone, interleukins, glycodelin A, and disturbance in Th1, Th2 profile, angiogenic factors, and leukemia inhibiting factors. So all these factors have their interplay when the implantation occurs. So they act on the endometrium. So whenever we are looking at the functioning of endometrium, we have to think about that. And thin endometrium is the biggest problem that we all face. And usually our knee-jerk response is to increase the estrogens. So estrogens affect the endometrial implantation via endometrial estrogen receptor alpha and LIF and IL-6. And these patients who have thin endometrium, they may have endometrial receptor dysfunction or low number, and therefore do not respond to physiological doses of estrogen. And estrogen can be administered orally, which is most comfortable, or sometimes we may have to give transdermally, and very, very rarely vaginally. Vaginal route is not very acceptable because estrogen causes lots of irritation. Then role of estrogen is there in promoting endothelial growth. It is controversial. And the doses, what should be the right dose? Most of us, we start with at the most 6 milligram or so, and sometimes we have taken it up to 12 milligram. But there is no consensus up to what dose we can go. And what should be the route? Usually we prefer oral, but sometimes we may have to go to other routes. And regimes are still not standardized. People go with fixed dose regime. Some people go with a step up regime. Then growth hormone we all know that growth hormone is being talked about in poor ovarian reserve. But now in a recent review and meta-analysis, growth hormone has been shown to improve endometrial quality and function, probably by improving blood perfusion, expression of genes, proteins associated with endometrial tolerance, and induction of IGF-1. So based on a subgroup analysis, a dose and time dependent relation between growth hormone therapy, combination therapy, and CPR, clinical pregnancy rate, was also found. So maybe the regimes which use growth hormone, they could be useful in improving the endometrium. Then sildenafil citrate, which improves the vascularization. So it may help in improving the blood flow of the endometrium. And a randomized placebo-controlled trial in patients with previous 2 failed IVF has shown almost 2-fold increase in chemical pregnancy. But the increase was not statistically significant due to small sample size. Then Botox, is being tried everywhere in the plastic surgery, in the cosmetics. So there have been some experimental reports, and it has been said that it enhances re-epithelialization of human keratinocytes and angiogenesis of endothelial cells. So animal experiments have demonstrated significant angiogenesis and enhanced endometrial tolerance. But this is there is insufficient basis for clinical trials. So still it is an experimental procedure which has mainly been used in animals only. Then conditions that can affect endometrium are anatomical problems like polyp, fibroid, adhesions, septum, submucosal myomas, adenomyosis, isthmocele, fluid in the endometrium, and sometimes necrotic material or RPOCs may be there. Then there may be impaired function and motility of the endometrium, especially in thin endometrium and in chronic endometritis. Then thrombophilia and immunological problems, they can all affect decidualization of endometrial stromal cells and regulation of trophoblast invasion. Should we be doing routine hysteroscopy for all IVF patients? Now everyone will agree that we have got such good transvaginal ultrasound that routinely it is not required. But when there have been 2 or 3 failures, these are the situations where hysteroscopy can be considered, and many subtle lesions can be found on hysteroscopy. And hysteroscopic correction can be done. You can, especially if there are polyps, then you get very good results when you remove the polyp. Then if the cavity is small, you can go for lateral metroplasty. And there has been and septum resection also gives good results. And there has been a study where it has been shown that hysteroscopic metroplasty for T-shaped uterus is a very fruitful procedure, and it should be considered in such cases. Then fluid in the endometrium, that is another nuisance. Many a time you are doing the stimulation and everything, and there is persistently that fluid is there. And there has been this study which says that persistent fluid in the endometrium cavity that resolves even after progesterone administration prior to transfer does impact the live birth rate. So in that situation, you should be ready to cancel this. You can freeze the embryos and transfer in the next cycle. So overall, it is associated with infertility and adverse pregnancy outcomes, and it can be very well detected on transvaginal ultrasound. And timing and the quantity of fluid appearance are both important factors to be considered. And treatment options are expectant treatment, do not do anything, and maybe that will affect the results, or freeze all the embryos and go for the next cycle, or transvaginal aspiration of the fluid. And this I have particularly done at least for 3 or 4 of my patients during the stimulation and embryo, and we transferred the embryo in the same cycle, and all those patients conceived. One patient had a big collection of fluid because she had a myomectomy in the past, and every time we do, there is collection of fluid. So what to do? So we aspirated that collection, and then we aspirated the fluid from the endometrium and transferred the embryos, and luckily she conceived. So when there is excessive estrogens, then sometimes that cervical mucus goes up and it is there in the cavity. So that can again affect the implantation, and maybe these are the situations where aspiration may help. Then you can give antibiotics to these patients thinking that it may be because of chronic endometritis, and then you may consider hysteroscopy, and if there is hydrosalpinx associated, then you may consider removing the hydrosalpinx. Then chronic endometritis. In the past, we all thought that endometrium is sterile, but now we have understood that yes, there are organisms, microorganisms even in the endometrium, which can lead to chronic endometritis. And recently the techniques are there. We have got RT-PCR techniques and all. So we are able to identify these organisms, and there are some indirect markers like CD138. If you do these markers, then you would know that yes, there is presence of organisms, and at the same time there is inflammation also. So very important to identify. And even hysteroscopy, on hysteroscopy also almost 60% of the chronic endometritis can be diagnosed by stromal edema or micro polyps or some necrotic areas. So it is very important to have that understanding and think approach about chronic endometritis, and if you can cure that, because you can cure them with appropriate antibiotics, and that may help. And these days, even for chronic endometritis, people have used PRP. When there is inflammation, CD138 cells are there, then PRP has been used, and that has been shown to have some success. Then microbiomes are also coming up in a big way, and they play important role in implantation by affecting the uterine environment. And disrupted microbial communities may lead to cytokine imbalance. Immune response is critical for successful implantation. And because of the inflammation, hormonal fluctuations, and impaired embryo-maternal communication, all of which contribute to repeated implantation failure. So all these things have to be thought about. And there is a big talk about probiotics these days, and a high presence of lactobacillus in the endometrium has been linked to successful live births. They can reduce Th1 cells and increase Th2 cells, which can improve implantation outcomes. It can create optimal microbial microenvironment in the endometrium. But sorry. But there have been studies where they have shown that intravaginal probiotics before embryo transfer do not always improve the pregnancy rate in recurrent implantation failure. So though people are using it, and it has been shown that in patients with RIF there has been an imbalance, dysbiosis, but still there isn't any proof that yes, they do help. Then there is a new thing which has been reported, and that is that when the microbiome's vagina, the imbalance is not being corrected, then in these patients, vaginal microbiome transplantation can be taken. So the microbiomes are taken from the donor and they are transplanted in the recipient. So this is also being considered, which seems to be a bit odd, but yes, these things are going on. Then autoimmune factors are also there which affect the endometrium, and especially when there is antiphospholipid antibody, thyroid antibodies, and anti-endometrial antibodies, and there may be imbalanced immune response. There would be elevated NK cells activity and reduced regulatory T cells. And the tests are available these days. So with the test, if you can diagnose that yes, there is a immunological problem, then that can be treated with glucocorticoids, intravenous immunoglobulins, tacrolimus, cyclosporin, thymosin alpha, intralipid, LIT. So all these things. But for this, I think a person who is really dedicated to this work should be doing this treatment. Then intrauterine instillation of HCG is also picking up, and HCG binds to LH receptor in endometrium. It secretes cytokines. It regulates endometrial receptivity, can increase invasive potential of trophoblast cells, and it is administered 72 hours prior or just prior to embryo transfer, and the dose is 500 to 1000 units. Then GCSF is another thing which initially people were instillating, and now more trend is using 60 to 300 milligram on the HCD trigger or embryo transfer, especially subcutaneous. And a meta-analysis has shown increase in pregnancy rates with GCSF administration in both fresh and frozen embryo transfers. Then intrauterine PRP, I'm sure half of you would be using PRP for the endometrial, especially the thin endometrium and recurrent implantation failure. And it is an autologous blood product containing high concentration of platelets, and it causes release of growth factors from activated platelets, results in angiogenesis, cell proliferation, differentiation, and modification of local immune response. It can improve clinical pregnancy rates and endometrial thickness, and has got promising treatment option. Most important is that how you prepare the preparation and what is the ultimate count of the platelets when you do it, and do it as soon as possible. Don't delay it for a long time because platelets have got a short half-life. Then peripheral blood mononuclear cells, which contain monocytes, T and B lymphocytes, they induce secretion of interleukins and growth hormones, promote embryo attachment and invasion, and increase implantation rate. The blood samples are obtained 3 to 5 days before scheduled embryo transfer, and they are isolated, and intrauterine infusion is done. And a meta-analysis, however, did not suggest benefit, but in a recent analysis in 23, it has shown improvement in pregnancy rates. Then stem cells are being used in specialized centers, and stem cell therapy helps to replace damaged endometrial cells and regenerate damaged endometrial tissue. And currently mesenchymal cells and hemopoietic cells are used, which are multipotent stem cells. MSC can be derived from bone marrow, adipose tissue, menstrual tissue, umbilical cord, and endometrium. And mostly it is the bone marrow which is being used. Human embryonic stem cells are a class of pluripotent cells originating from cell mass within blastocyst, and they have capacity to, but one important thing is whenever you are using stem cells, you always have a worry, but maybe endometrial cancer will develop, or adenomyosis will develop, or the child born out of afterwards may have teratoma. So though there have been many clinical case reports, but still clinical trials are small and high quality evidence is lacking. Then endometrial scratch biopsy, which was very popular few years ago, and it was done on day 7 of previous cycle and day 7 of embryo transfer. It improved pregnancy rate and pregnancy rate in previous failed ET cycles, but it is not recommended by ASHRAE, and the studies have shown that it is really not of much help. Then endometrial motility and its impact. Again, motility is to be considered when you are transferring, because it plays a role in tissue modeling during embryo implantation and endometrial regeneration. And atosiban was thought that yes, it will be very good, and initially we started using it, but then again the studies have shown that it did not have much impact, so most of us have stopped using it. Then endometrial receptivity, the ERA test.
Dr. Asha.
Yeah, I'm about to finish. So here window of implantation is displaced in 25%. So it is thought that if you can detect that and transfer accordingly, then the results will improve. But again, this recent randomized clinical trial, it showed that there wasn't any difference between personalized embryo transfer or the routine embryo transfer. So again, there is a question mark. So basically, after all, we feel why not just think about expectant management, because time is the best healer. The endometrial lining has a high regenerative potential, especially after resolving underlying issues like infection or inflammation. So especially in cases of chronic endometritis or inflammation or post-surgical recovery, I think if we give some time, things will improve. And at the same time, you can give them nutritional support, you reduce the stress, so the cortisol will also reduce, and hormonal monitoring and regular ultrasound. And the day you feel that yes, this time the endometrium is good, then you can go for transfer. And studies have shown natural recovery within 3 to 6 months. So my conclusion is that with the improvement in embryology lab techniques and quality of embryos, a lot of effort is focused on improving the endometrium for implantation. Measures are being applied, but none seems to be very promising. Focus is on intrauterine instillation of HCG, GCSF, PRP, stem cells. Research is needed to really work on genetic, immunological, anatomic, hematological, microbial, and endocrinological factors and their interactions. So with that, I would like to thank you all for the patient listening, and I would like to invite you all to Lucknow ISAR and then afterwards to Indore for ISAR Embryology conference. So you all are welcome, and thanks again for patient listening.
Thank you, Dr. Asha, for this elaborative presentation. Humongous work done, and we learned a lot from this. We'll take, in the end, we'll have the questions answered. So you can, thank you so much, madam.
Thank you.